Hello and welcome to NICE Podcast. We are broadcasting live from the National Innovation and Commercialization Expo, NICE 2025, coming to you from the World Trade Center, Kuala Lumpur. This is the definitive platform for turning R&D into market success, and we're here to cover the key conversations shaping Malaysia's future. I'm your host, Ian Ong, and joining me today is Professor Dr. Sazzli Shahlan bin Kasim, cardiologist and health economist from the University Technology Mara. Thank you for joining us today, Prof.
Hey, Ian, my pleasure. Thank you for having me.
So, earlier on, we had a nice sort of a panel discussion with Prof, where the topic of the panel was Malaysia's healthcare challenges. Can innovation save time, save cost, and save lives? And I think, Prof, you're no stranger to the topic of innovation.
Yeah.
So maybe you could share a little bit with us about your journey with innovation.
Okay, the journey, that's very interesting. So it's a very long journey. So I'm almost middle age, actually past middle age already. So I'm quite old, despite looking quite young. So a lot of people will say that too. Yeah? But to you and to me, kan? But so I was trained in Ireland. So I came back to Malaysia about 12, 13 years ago. And I started off with UITM, and then we started our cardiac center in Sungai Buloh. So that was on the proviso that there was no cardiac center in Sungai Buloh or the north of Selangor at that point. So in a way, that was a healthcare innovation, a university center providing cardiac service in Sungai Buloh. But when you do that and you realize that a lot of people are coming in with heart disease, and these are young people, 30, 40, 50, people who are still working, having kids and large families and still being very, very productive and suffering from heart disease. And then you realize there must be something wrong with our country or our population. So that was the question. How do I find ways to prevent these things from happening? How do I reduce the number of people, say, getting heart attacks or dying prematurely of heart attacks, and saving the wives from crying, saving the kids from losing their dad, saving the mothers and fathers from losing their son or daughters, and so on. So these are real emotional issues that if you were to face it on a daily basis, it kind of like eats into you. But I was determined to figure out a way. So about 10 years ago, we started looking at our data, our registry, our hospital data. We tried to figure out predictors of people who are at risk of dying prematurely. And from there, then we decided about 5 years ago, when COVID hit, how do we actually deliver some of these preventive advices to our patients with heart disease and when they're at home. So we got a small grant from Yayasan Inovasi Malaysia, which is part of MOSTI as well, to deliver remote cardiac rehab. And a lot of people think rehab is only for people who broke their leg or got involved in an accident, who cannot walk and stuff like that. Your heart needs rehab too. You just had a heart attack, you need to recover. And you cannot just recover by reading Google. If you want to attend your doctor in hospital, if you're in a private hospital, okay lah, he can attend to you whenever at your beck and call because you're paying him money, but it costs, right? But a lot of our patients, public patients, government patients, people who go to hospital kerajaan, and they cannot really access this cardiac rehab service. It's not widely available. So what we tried to do back then, 5 years ago, was to try and deliver cardiac rehabilitation at home. Were we successful? We failed. We cannot. Why? Because number one, we were not able to scale it. Number two, our solution, our patients cannot use it. And we forgot, our patients are, a lot of them, makcik-pakcik dari kampung, or elderly people, or people who are not tech savvy enough to follow the instruction on the phone. And then from that we learned we have to do better, we have to do it differently. So along the way, I also assumed many roles. Not only am I a cardiologist, I was also a hospital director, building UITM Hospital from 2016. I gave up that post in last year. That hospital achieved MSQH, changed the name. We had the King and the Sultan Selangor visiting. So that was a lot of fun. But having a lot of fun building hospitals and operating it also taught me a lot of problems associated with healthcare, like lack of electronic medical record. We had to build our own. So the UITM IT department actually, garnered a few people, about 10 to 12 of them, and actually code our electronic medical record from scratch. Which we use, and it's an end-to-end solution. So that's a great innovation that saved the country about 70 million ringgit. And we built on from there, because when COVID arrived, and we approach it as a whole of government, meaning universities have to be part of MOH effort, right? And we were in Sungai Buloh, which is right next to Hostel Sungai Buloh. Our cardiac center or mini hospital was in Sungai Buloh. And we learned very quickly at that point what the leadership came from most team as well as MOH to deliver vaccine, to decant, to accept patients who are post-COVID for recovery and rehabilitation into our hospital, to help Hostel Sungai Buloh offload the ED congestion. And we were working very, very closely. We had a really good time, but it taught us a lot. And the one thing that we realized quickly in UITM is that a lot of processes can be automated. A simple thing. Patients, when they come to the hospital, and we touched this during the panel discussion earlier on, patients, when they come into the hospital, they have to park their car. Have you been in the hospital? It's so difficult to park your car, right? Because there's no parking. So at the end of the day, you have a heart, you triple park, or you have heart condition, you have to park like 3 kilometers down the road, you walk to the hospital, you can heart attack. It's illogical. So scenarios like that gives us and pretty much nudge us to do something. So we created a patient app, which patients actually use as a patient of Hostel UITM. They register and they can see their diagnosis, they can see medication, stuff like that. And we wanted that they can register or check into their clinic without even being in the hospital. And are only called in when their numbers are up, when it's about their turn is about to come up. So they don't have to congest the waiting area. This is during COVID. This is during COVID. Like, you don't want to have a lot of people in a congested area. Now we don't care, so you can stand next to each other without masks and so on. But queue management system, crowd management system, what happens when patients have seen the doctors, do they have to queue for a long time waiting for the medicine? And a lot of the time when patients come to the hospital, they spend a minimum of 6 to 8 hours. Seeing the doctor takes about 4 hours. Waiting for medicine takes another 2 or 3 hours. It's like a whole day wasted.
Personally, that happened to me like many years ago. I went to Hospital Shahlan for a dog bite. So I think I was there at 10 a.m. and then I left the hospital about 6 p.m.
About 8 hours. Like in 2012, I had appendicitis, and I went to a government hospital at 3 a.m. By 9 o'clock, I was still not seen. So I self-discharged. I went to a private hospital and was looked after immediately. But I was lucky because I had a medical card. So these are the things that is a bit unfortunate to happen to a lot of people. Not because we don't have a system, but sometimes the system do not attend the needs due to our criticality. I was a healthy young male. Even if I were to have appendicitis, I probably would die. So as a healthcare practitioner, we take all these things into account. So you have to attend to this very, very sick before attending to somebody who's less sick. We triage them. And we hope that it works. And most of the time it works, but sometimes it doesn't work. But these are pain points as a patient. On the other side of the table, have to experience, and it's not very nice. So a lot of the time you ask yourself, how do you make it better? So part of that journey is that in terms of innovating, in terms of process automation, coming to hospital, mapping out their journey, calling them when they need to, maybe posting out the medications to them at home. We came to a point where we actually ventured and collaborated with a private pharmacist to deliver a cold chain solution like insulin to patients' home. Of course, patients pay a bit, but you imagine if you were to come to the hospital, which is like 20 kilometers away, you have to pay for petrol and toll. You have to look for parking and pay for parking. You spend 3 hours waiting. You would, I swear to God, you would rather just pay 10 ringgit to get the medication delivered to you. And in the future, I really hope medications can be dispersed by any pharmacy and billed back to either the government or the university or the private hospital or to the insurance or to the patient. It depends on mechanism.
Is that something that's covered by your health economics side of things, Prof?
Oh, when I did it. So I did a master's in health economics and cardiovascular outcomes in LSE because I realized when I was asked to direct and build and operate a hospital back in 2016, my skills was limited to being a clinician and consultant cardiologist. I built a unit, teach people how to look after sick hearts and look after sick hearts and patients along the way, but not build a hospital. It's totally different. So I needed more leadership, more administrative, more process skills embedded in me. So that's when I did it. And along the lines, the master's degree pretty much taught me of how to look at the overall picture and balance resources, because that's what economic is, right? You have to really balance your ins and outs and what's in demand and so on. And also to look for loopholes and gaps so that you could improve experience and outcomes based on those gaps. That's what I learned from that particular degree. Applying it to the operation of UiTM Hospital was a lot of fun. Applying it to general life is a lot of fun. So when I stopped and when I pivoted away from hospital management and now directing a research institute, we call ourselves Cardiovascular Advancement Research Excellence, or CARE Institute, CARE Institute. Yeah? So CARE Institute is what we call a High Institute Center of Excellence, dedicated for research. It's under Ministry of Higher Education. We were acknowledged this year as being able to achieve that standard. To achieve that standard, they look at your track record for the past 5 years to see whether or not you're publishing enough, you're getting enough research grants, you're producing enough PhD and master students. So there's a lot of criteria.
Doesn't sound easy.
Not easy, but our team were able to cross that road, and it was my predecessors really that did all the work. But because it's cardiovascular disease oriented, and I had a interest in researching cardiovascular disease, especially in terms of machine learning, data analytics, how to make life easy for people. I think it was just a natural progression for me to move from managing a hospital to managing a research center for cardiovascular disease. So that's what I'm doing right now.
But cardiovascular disease is the number one? Number two?
In Malaysia,
Yeah.
it's a number one killer, except for 2022, 23, that's when COVID came in. Pneumonia was number one.
That was sort of a sort of very external kind of a factor. But
Yeah.
as you were saying earlier, we are very innovative in finding ways to sort of meet our ends earlier by roti canai, teh tarik, nasi goreng, semua goreng, minyak.
Yeah.
So we love our food. Malaysians love our food, and
Yeah.
I think we are acknowledged to be quite sort of avid eaters of food. But that brings about with it the sort of issues that we're looking at today, like
Yeah.
cardiovascular disease being number one killer of Malaysians. How about on the other side of things, looking at prevention? Is there something that sort of can help Malaysians eat the way that we still eat, but also reduce heart disease, or is it sort of a culture change that we need to look at in terms of, say, we just need to eat healthier as well? You know, we can't always have our favorite teh tarik and roti canai.
Absolutely. So, from a public point of view, you hear the reports such as the National Health Mobility Survey, NHMS, which is conducted biannually to scope the health of the nation. From there, we know how many people have hypertension, diabetes, obesity, smoking, cholesterol, how many are B40, M40, T20, how many kids are young, how many people who are old, how many people living in a household. So it gives you a great social insights, and health is one of them. That's on a very overall point of view. But if you work in a hospital like me and dealing with sick people coming in with heart disease, and you realize that there's probably a bit of disproportionate number of young people coming into hospital with heart disease. So what is wrong? So Malaysia is very lucky because we have a cardiovascular database registry called the NCVD, National Cardiovascular Database Registry, that was championed by the National Heart Association Malaysia as well as MOH. So it involves 23 different hospitals around the country, feeding in data pertinent to people who have had a heart attack. And as an academician, I was able to access the data to look at the nitty-gritty. So what I realized, or what we realized, was that 1 in 5 people with heart attacks in Malaysia are actually under the age of 50.
Yeah.
1 in 5.
Makes sense.
Yeah. So these are young people. 15-16% are actually below the age of 45. And the drivers are smoking, diabetes, hypertension, and lifestyle issue like lack of sleep and stress. That's quite common. And
Stress among Malaysians.
and Malaysians,
Berpisah tiada.
oh no, we are very hardworking people. We love working. I just shared with you last week. I had this guy whose cholesterol was normal, 4.5, does not have diabetes. His blood pressure checked out okay, slightly sedentary, but over the past 2 or 3 weeks, he's an accountant or he works with a bank. I'm not too sure. He was highly stressed. He was not able to sleep. He was only sleeping for 2 or 3 hours, and he had a massive heart attack. He came to the hospital just at the right time. We were able to salvage, and he got home okay. But stress, you do not, we under do not impress much on stress, but stress plays a big factor for the burden of heart disease. So anyway, seeing all this and seeing the type of people presenting and the number of people who are young presenting with heart disease, we realize as a clinician, when I see a patient, like for yourself, for example, I can straight away score your risk. Are you low risk or high risk? If I think you're high risk, I'll treat you or I'll intervene. Either I'll tell you to maybe you should exercise or go to the gym. Maybe you should check your cholesterol twice a year. Maybe you should check your sugar level, or I'll give you some medicine. So these are all the intervention, either lifestyle intervention or actual drug prescription, right? Makes sense. But the risk score that we are taught to use do not come from Malaysia. It came from the US and the UK, and maybe China and Japan. It's not exactly locally driven, locally validated, and but due to the lack of data, our own data, we're not able to generate our population's risk score. So then I realized maybe that's the problem. That's why a lot of 30-year-olds are getting heart attack, because we think they are low risk, but in actuality, they're not low risk. So we're undertreating them, either by not prescribing enough exercise or lifestyle, whatever, or not giving them enough medicine to reduce their risk. So that could be a reason why. So that's when we were able to access the NCVD data, as well as our hospital data, as well as a few other research data, and we look at it. We look at what are the driver of risk, and are these young people are truly low risk, and unfortunately they're not. Unfortunately, for Malaysians, because of our geolocation, our food culture, our intolerance of the hot sun, meaning we don't exercise enough, our environment full of pollution as well as nyamuk, dengue, so we don't go out to walk around enough in the evening. We are restricted by all these things, resulting in a high burden, high risk population. So then it changes how you approach things. If a lot of young people are at high risk, should we not intervene them a bit more aggressively? And I'm not talking about doing operational procedures. I'm talking about simple things: identifying the right person, giving them the right advice, giving them the right nudges. So these are the things that we need to start thinking about from a public health point of view, because now the data is real. So when we talk about innovation, we really need to understand the real pain point. So that's why I take you back, or I'm telling you this story of how it actually starts. And my pain point is very real, because people die from it. And I'm not seeing the right solution out there. The solutions available are mismatching. They're not exactly addressing the young people. So I said to myself, might as well solve this problem.
I think anecdotally speaking, nowadays you see a lot more cases of younger people, and then these are people who their relatives or their friends will say, this person is healthy, they exercise all the time, but suddenly one day when they're out on a jog, they keel over, heart attack. And so then people sort of go, but how? They've been living correctly and all that, but somehow they get that heart attack. So I think it's exactly like you say, the risk factors haven't been identified or haven't been sort of worked on correctly. And I think nowadays people are sort of maybe becoming a bit more aware about this, because the conversation is becoming a bit broader in the sense of data. Like nowadays when people talk about AI models for healthcare as well, then they're saying, okay, how has this model been trained? And then it sort of comes to light that this model has been trained with data that isn't local. And then it goes like, okay, but then how can that be helpful to us in this context, because our context is completely different from where this model has been trained. And that's sort of where the awareness is coming to people nowadays.
Absolutely.
And that's I think something that was very important that you brought up as well.
Yeah, so we're moving away from being a servant-master relationship, being colonized, to being able to think for ourselves. We can't really use Western data that's been shoved down to us, well, for the lack of our own data, to make decisions for ourselves. We can use it, we have to calibrate it, but now we know that it's not that accurate. So we're better off to have our own data. And as we've discussed, we have a lot of data. We have a lot of data in very different places. But trust is also another issue. You have data, I have data. Do I trust you to use my data? What's my PDPA agreement? How will it affect the people who sign up to my data? And we need to be more transparent in terms of how we use data. Hearing news that data is being sold from massive data lakes, apps that is driven by the government is not a very nice feeling, because we don't know what is actually being sold. Is it your phone number? Is it your address? Is it the number of kids that you have? Is it your kid's identity? So that level of trust must exist. And for that, you need strong governance, strong regulation, as well as strong implementation through the whole of society, be it the government, be it services, agencies, or be it industry players in the private sector, as well as the end users themselves. They must all have the right channel to voice out their concern and address and talk about this if we were to move forward equally and reach greater heights, because otherwise we'll always distrust each other. It's very hard to move out of that mindset.
So Prof, like you have a sort of a unique position here because you are both innovator and also end user.
Yeah.
Because ultimately we are all end users of the healthcare system. So from your perspective, how can we sort of bring that trust up to a required level, and what are the sort of cybersecurity measures that you see are really effective and can really help us bring that to the level that we need to be at?
Okay, so I think after being on this journey for the past 10 years, what I realize is that trust is, you have to build trust, you have to be fair. A lot of people have issues with trust because there's always a hidden agenda that is not being declared, and therefore it makes it a lot harder to trust. It's very simple. The reason why there's a hidden agenda is because there's probably dollars and cents, ringgit and cents behind it. There's money to be made, and why would I disclose it to you? If I'm going to have a lot of money, I won't want to share it with you because of whatever factors that drives me to make more money. So in a scenario where you're not driven by money, you're driven by a passion to help people, to prevent heart attacks, to reduce the burden of disease, it gives you a slightly different angle. I always say to people, this algorithm or this predictability, we want to make it available for free. And true enough, we put it on our website. Just want people to use it, and it's actually not that visible, because to make it visible, then you need marketing. So all these kind of things, just like Prof said, oh, you need marketing, Prof Sazzli. Okay.
Then that's cost.
It's cost, right? So that's a different aspect to getting things out there from 0 to 1. But we learn along the way, and the journey may not be quite straightforward. It's always winding, but the main thing is not to give up, and it's to keep talking. And I think Meranti and Mostly and all the agencies have been doing a great job for the past 5 years that I've known you guys, in terms of creating awareness, in terms of bringing the networks in, being people with vision and innovation, as well as enabling the ecosystem to move forward. And I think that's very, very important.
Thank you, Prof. I think that's sort of the things that we really want to hear as well, as sort of ecosystem builders and the people who have a passion to sort of engage in not just nation building, but also driving the wider ecosystem and promoting more Malaysian-based innovations, especially.
Yeah.
I think that's all the time that we have, though. Thank you very much for joining us today. Thank you, Prof.
Thanks.
And we hope to see you again.
Great stuff.
Thank you.
Enjoyed this conversation.
All right. Thank you.
Bye-bye.
See you soon.